Our final debate is complex PCI with CTO revascularization in MCS-dependent patients should be routinely offered. And the pro is Dr. Arain.
Well, it's a pleasure to be here. This is a debate which hopefully we can solve. I'm just kidding. Okay, so I noticed before the debate that the program has changed. My speaker is not the originally planned speaker, which means you must be winning if they have to change the speakers and bring a big hitter to challenge you. So when Marwan gave me this topic, complex PCI with CTO, PCI, and percutaneous MCS-dependent patients, it got me thinking that this is not a bad topic to talk about. It's something I do sort of routinely. Maybe not everyone's PCS, MCS-dependent. But then I said, the devil is in the details. What does he mean by routinely? Like, when do we do this routinely? And as someone pointed out, these are not routine patients. And that got me thinking that this is sort of the trick that I have to kind of overcome if I'm going to win this debate. The challenge of defending a seemingly indefensible proposition. So first of all, is this a common clinical scenario? The answer is not really. What's the data? There isn't any. Now, there's an advantage and a disadvantage to that. It's like a scatter plot where you can make any line you want, any curve you want to fit your desires. And so, we'll see how my colleague, my challenger addresses that. Is the argument that's being made tenable in any way, and or is it applicable or generalizable to the clinical practice? And most importantly, what does Marwan think of me as a friend to give me a topic this tough? So, overcoming some of those issues. But why is this even a question? Why ask a question if it really didn't have any relevance? But because it does have relevance, right? So the percutaneous MCS-dependent patient with complex coronary artery disease is not a unicorn. We see it in our labs all the time. ACS is the most frequent cause of cardiogenic shock. And while the title does not, and I'm going to preempt the panel here, while the title does not talk about ACS shock, really if you're talking about revascularization, it is a shock in a patient who has multivessel disease. So you have to assume that ACS is part of it, could be STEMI or non-STEMI. Secondly, we know that patients with STEMI are at the highest risk for cardiogenic shock, and multivessel disease and CTOs are prevalent in this population. In fact, there are studies to show that the number of CTOs predicts your outcome of shock. So people who are in shock, if you don't have a CTO, tend to do better if you have one or more CTOs. So here's a case presentation of one of these sort of not unicorn patients that we see here in Houston, 48-year-old mechanic with not the best insurance in the state, came in with a non-STEMI and cardiogenic shock to an outside hospital, had hypertension, abdominal pain, had a mild troponin elevation. They took him for an echo, EF was low, and he had moderate to severe mitral regurgitation. Now, he had severe multivessel disease. I'm going to show you this in a second. And he was referred for surgery at the local hospital, and they turned him down. If I can just show you, it takes a minute to load. And you can see that this is what this young man was living off of. You can see that he's got occlusion of his LAD, occlusion of his all of the branches of the circumflex, really. He's got the diseased ramus, which seems to be the only thing that's working. And then you see that there's actually occlusion of the RC also. So here you can see he's living with not a whole lot. And typically in this situation, they did the right thing, which I guess for them would be to call a surgeon. Surgeon said no. And so they decided to treat this patient with a balloon pump. So they put a balloon pump in him, did a right heart cath, kept him in their unit for about 2 weeks, optimized him, put him on guideline-directed medical therapy, and then sent him home because that was his best option. So that's your unload, or quote-unquote unload option. He actually was discharged 8 days, and 5 days later he came to our ER with profound hypertension and worsening renal function. And the always question is this patient taking his medications, or is he taking them too well? Is he over-diuresed? And so he underwent a right heart cath with one of my colleagues, and his PS saturation was 38%, which is alarming. His lactate was about 4.5. His creatinine had jumped up to about 3.8 from his baseline, whatever it was. And so they ended up doing an Impella placement. And the question then becomes, for this patient who is now severe cardiogenic shock, multivessel disease with poor surgical options, what is the best treatment option for this patient? Is it a high-risk CTO PCI, because that's all he has, honestly speaking? Is it high-risk CABG? Well, there's no real targets, but you can see. Should he be sent for an LVAD workup? And sometimes you need to check with insurance, see the social support. Is he capable of handling an LVAD at home? Or should he be worked for a heart transplant? And these decisions are not easy and quick decisions. So arguably, this is what makes our patient percutaneous MCS-dependent patient. So the patient that we talk about in the debate, this is that patient. So really the question here is not so much the CTO PCI, because for a CTO operator, that's any PCI, right? So we don't distinguish between CTO or CT PCI other than the equipment. For us, it's a matter of revascularization. Should these patients be revascularized? And the answer is yes. We would all agree to that. Timely reperfusion can prevent irreversible end organ damage. The role of the device here is to prevent that irreversible shock, keep it on the hemodynamic side, and minimize those derangements. The role of PCI is to improve survival, and we talked about the shock trial. And is it ever too late to reperfuse? So now that the patients come in, it's taken you 2 days to make a decision. Well, in the shock trial, the optimal time was within 11 hours, but if it's more than 48 hours, will the patient still benefit? And so it's a matter of getting from point A to point B. Point A is culprit shock, where it says that if you have someone in shock who has had an MI, only treat the culprit vessel. Now, I could argue that we don't know what the culprit is in this particular patient. And point B is complete, right? When the patient comes in with a STEMI, they're not in shock, but after you treat the culprit vessel, you go ahead and do complete revascularization, regardless of whether it's CTO or not. And really what you want to do is take the patient from point A, where they're in shock, and stabilize them to get them to point B, where they now have stable disease, and you address that and give them the best option, best of both worlds. And this is where the role of the MCS comes in, right? So this is what the MCS offers these patients. And we saw in danger shock, despite its many flaws and shortcomings and the critiques, that ultimately for selected patients, an upfront strategy of using unloading in addition to revascularization actually has a mortality benefit. So what do we know about CTO PCI in 2025? It relieves angina and dyspnea. This is slightly smaller font size because it's not randomized data. This is registry data, improves EF, improves outcomes after ACS. Some reports to suggest improves incidence of arrhythmias and improves mitral regurgitation. But one thing it does not do is improve mortality. So we don't do CTO PCI to improve mortality. That's where the long-term therapy comes in. Why use MCS during CTO PCI? Well, there's hemodynamic support, advantage of LV unloading, improved myocardial perfusion, fewer ischemic complications during the procedure, especially if you're using some atherectomy devices, and more complete revascularization. Advantages of PCI over surgery: lower procedural morbidity and mortality, avoid sternotomy. So if your patient is not going to recover the LV and now they need to be bridged to an LVAD or go to a transplant, this allows you to do that rather than they go through bypass, which doesn't work, and we see that all the time. It's a trial of perfusion just to see how much the hemodynamics will improve with the mitral regurgitation involved. And finally, it allows you to wean the MCS off for these patients. Now, there's some certain challenges, such as unknown potential for recovery. Structural causes for CS will often coexist. The comorbidity of the CTO PCI itself. Technical success rates are good, but again, there is some issue with it requires expertise and timing of revascularization. So in conclusion, let me just share what happened with our patient. He underwent revascularization of, if I can go back one slide. Will it load? I think it takes a few seconds to load. We're almost done here, sorry about that. Okay, so he underwent, in a single procedure, we were able to revascularize the ramus, the third obtuse marginal, the proximal 2/3 of the LAD, and the RCA. And this is what the final result looked like. And actually, the patient was readmitted 10 months later because of instant restenosis in the only vessel that was open when he first came in. All the CTO vessels were open, which again tells you that CTO PCI actually is durable. And 2 years on, the patient is doing well. He has not required VAD or transplant and has only been admitted for heart failure one more time. So final thoughts. Complex PCI with CTO revascularization in percutaneous MCS-dependent patients should routinely be offered. Yes, it should, with the caveat that the patients are expected to survive to discharge or to surgery, with the goal of weaning these patients off of the pMCS and allow them to get the definitive therapy that they need. Thank you.